the recording and we can get started with today's session. All right. Welcome, everyone. My name is Erica Norman, and together with Janice Toulousan, we will be your host today to take you through this requirements gathering session for the Geriatric Assessment Program in Richmond. So we've got some introductory slides that will take us probably until about 1:15. And as we shared before, that your provider physician will be joining us at 1:15. But before we begin, I'd like to start us off in a good way. So I'd like to take the opportunity to acknowledge with gratitude the land that we're gathered on, the traditional and unceded territory of our Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. And for that, I am grateful. And then taking us to our agenda slide. And I'm seeing everyone nodding their head. Yes, so the slides are moving forward, correct? Excellent. All right, so our agenda will be introductions and some background slides that'll take us until about 1:15. And then we'll have our first half of the session, which is really nurse, case manager, and provider focused. Here, we're going to look at some workflows specific to those roles. And that'll take us probably to about 2:15. And then we'll take about a 15-minute break. And we'll come back for the second half of our session, which will be from 2:30 until 4:30. And this is really going to be focused on program support, nursing, and allied. And then we'll really look at Cerner and we'll look at kind of what would happen with Cerner for a day of visit. Any questions with the agenda? And then we'll end the afternoon with questions and then a summary of next steps. All right. And of course, we always just encourage folks, take care of yourself through this. It is quite a long session. So if you need to get up and stretch or take breaks, please do that beyond the existing breaks that we already have. Just take care of yourself through this work. All right. There are a large number of people on the line. So what we ask is that you mute yourself when you're not speaking. When you are sharing, we ask that you please state your name, and this will just help us in taking our meeting notes. And if you have any non-urgent questions, we ask that you put them in the chat, and my colleague Eric is going to be monitoring that chat and just jumping in with any questions to help Janice and I as we journey through this material. And then as I shared earlier, this session is being recorded via Zoom, and we will post it unpublished to YouTube to reference in the future. Okay. So moving on, I'd like to start with introductions. Why don't we have folks on the team? So in that subject matter expert column, if you are from the GAP team, if you don't mind just saying your name and your role on the team for everyone on the line. Sally, can you start us off?
Hi, I'm Sally Kong. I'm the interim manager for the GAP program.
Thank you, Sally. Marina, are you on the line with us?
Yeah, I'm Marina Friedman, the nurse case manager for Geriatric Assessment Program.
Excellent. Thanks, Marina. Sally, is there anyone else on the line just yet? Others are probably joining us at 2:30, eh?
Yeah.
Okay, okay. My name, everyone, is Erica Norman. You may have worked with me, and my colleague Nicola Butler is also working on this project. She couldn't be here today, but you may have worked with us before for community systems. So we've worked lots in Paris and Profile EMR. And this is our very first time working in the capacity of Cerner for this community space. So we're really here learning under the direction of Janice Toulousan and her team, and along with the support of a big CST team who was on the line today, which we're very grateful to have with us. So you may find that as I'm speaking, the CST team and Janice and her team will jump in with pieces because there may be information that I don't know as we're just learning and journeying into the community space with Cerner. Janice, do you want to say hello? Because I know you're going to be sharing as well, just so people know your voice.
Of course. So
Thank you.
Janice Toulousan, as Erica mentioned, I'm a senior manager with the VCH Clinical Informatics team. And so my role here is to really help support Erica and Nicole in their journey with, learning Cerner, familiarizing themselves with Cerner so that they can better support this clinic moving forward. Yeah, so here to mentor, teach, ask, answer questions.
Yeah,
And for the purposes of today, I will be the one that will be providing all the demonstrations in Cerner.
thank you, Janice. All right. And then I won't go, in the interest of time, I just want to highlight that there's many folks from many different areas of the CST team here joining us today, and we're so grateful for your time and for joining us. Because there's many folks on the line, we've got them listed here, but what they'll do is as they're jumping in their different areas of content expertise, is they'll introduce themselves as they share. All right. So we're at 1:10 and 1:15, we're awaiting our provider. So I will go real fast through these next ones. So the purpose of today is to confirm Cerner build options and look at a design for your clinic. We're going to look at referrals. We're going to talk about triage. We're going to talk about what happens in a clinic visit, how you document, and then discharge and follow up. You'll get to see all of that later. We also wanted to share with you the guiding principles for change, and these are driven out of the CST project. So we want to share those. So the first principle is all around no change for the sake of change, but really having the drivers of safety, regulatory, financial, and content, and you can see the descriptions there, driving any change that we're making in a system. The second principle is really around enterprise design. So CST Cerner is designed as a system to serve many areas. So there's a lot of functionality that is the same and used in different places, is essentially that piece around enterprise design. And then guiding principle number 3 is around really focusing on must-haves, and then writing down and documenting that nice-to-haves are really important as well, and that the project really takes the perspective as we get the must-haves done, and then we're aware of the nice-to-haves, and maybe something that informatics comes in and does a little bit later. Something to be mindful about with this particular project is it's really on an accelerated timeline. So for GAP, many of the other programs in Richmond are a little bit farther along in terms of design. So we are coming alongside a little bit late. So going through the design process quickly, and we really want to ensure must-haves. And then, as Janice mentioned, myself and Nicola will be supporting this clinic long-term with Cerner, and so we can explore the implementation of nice-to-haves kind of after implementation. Anything more to say there, Janice?
No, I think you've caught it all.
All right. And so those are kind of the guiding principles of CST. The next slide takes us into what is a subject matter expert, or you'll often hear the word SME and wonder what does that mean? So that means subject matter expert. And so we're really glad to have you here today, Sally, Marina, and then the rest of your team joining later, because you know your workflows best, and we really want to talk about those detailed workflows with you so that we can design with and for you as we journey into this. And it's really about collaboration to inform the design. And I've got a couple slides on basic clinic information. So Sally, I will ask that you just validate that these are true. I think in a previous meeting, this was confirmed. So I'll just pause so you can take a look at that. Thumbs up, Sally. Oh, Sally, if you're speaking, you may be on mute.
Sorry, quick
Not to
question.
worry. Sure.
Written fax number, this will be changing?
Yes, my understanding is that this will be changing.
Okay,
And so we just wanted you to have a heads up about that.
okay. It's because it's going to become a right fax number?
Janice, do you want to speak to why we're changing the fax number for the clinic?
So right now you have a shared fax line that goes to your right fax. So that isn't changing. That is going to
Okay,
be staying as is, the way it is with the same phone number. But for all of the clinics in Czech that are moving to Cerner, each clinic will be requesting their own new digital fax line in Cerner so that they can use that. So in this case, you would have a digital fax line in Cerner and it would be a new number.
okay.
Does that
But
make
then
sense?
the existing right fax number would stay the same?
Yes, that's correct.
Okay,
Because not all the clinics are moving to Cerner and Czech. So you'd still need to keep that right fax number. And we're not changing that number because it's shared with other clinics that are not moving to Cerner.
okay. Because Gap has their own right fax number. It's not a shared one. And I was just curious because the majority of our referrals are external.
Okay. That's good to know. We didn't realize that you had your own fax line. And that you didn't use the shared one in Czech.
Yeah.
So in that case, should we just use the current fax number that you have for GAP, and then any external referrals that come to you would just go into the Cerner's, like the Cerner digital fax line, and then the clerk can just action that referral and upload the document to the chart and everything.
I think that would be helpful. Marina, were you wanting to add something?
Yeah, the telephone number that shows here is not correct.
Oh, thanks, Marina. We'll correct that.
And actually, the fax number is not correct as well as the telephone number that shows here. The correct fax number is
Right, yes, sorry. I was supposed to say that next. I'm like, that's not the right number.
Thank you. We'll correct
Erica,
both of those. Yeah.
I just sent it in the chat.
Thank you. We'll correct those. Thank you.
And yes, like I mentioned, it is our own right fax line. It's not a
Okay.
shared one.
Excellent. I'm glad we validated. Thanks so much for this. And I'm aware that did we just have the doorbell ring? Did someone just join us, Eric?
Yeah, Dr. Leo Lai just joined us.
Oh, wonderful. Welcome, Dr. Leo Lai.
Hello. Hi, everyone.
Nice to meet you. My name's Eric. Great. Thanks so much for joining. My name's Erica, and I'll be hosting alongside Janice Toulousan today. We've just gone through introductions and backgrounders, but I understand that you've been through Cerner process before, so we were going to just jump right into content now that you are on the line with us. Does that work for you?
Sure. Okay.
Oh, okay, excellent. And what I'll briefly do is just show you the agenda while we jump into your content. So we have you with us, I understand, from 1:15 to 2:15. And we want to focus this time looking at the provider and nurse case manager workflows. We've got some discussion time in, and I know that you sent over an email with some really important points this morning. So we wanted to address some of those points within that discussion time. We also have some design decisions that we wanted to check in with you about. And then lastly, we wanted to talk a little bit about fillable PDFs and profile EMR. Does that sound all right to you?
Yep.
Great. And do you go by, what do you prefer to be called? Dr. Lai or Leo?
Yeah, my first name's fine.
Okay.
Thanks.
All right. So the first thing that we wanted to speak, Leo, Marina, the first thing we want to speak with you about was future state and talking about the potential of having a triage nurse for when referrals come in. So what we've done is just created a slide with a possible workflow. It is here for discussion only, but we had some questions around if you did have a triage nurse in future, what would that look like in terms of adding them into your existing processes? So I'm going to pause there and allow some space for my colleague Janice to weigh in a little bit further.
No, I
Thanks,
think you've
Janice.
no problem. And Leo, I think we met, I think in an initial meeting with Dr. Johanna Vanilla, and we were kind of discussing what options there would be. So I'm now here supporting Erica with moving this clinic to Cerner, given that Erica and her team are very familiar with Profile in Paris. I think that's the reason why we're working together in transitioning this clinic. And so, Sally, just leaning on you as well. I know that there were some operational conversations about potentially like bringing in a new role for this clinic. And so, our understanding is that this new role would take on the triaging process, which is currently done, amongst physicians right now. And so just looking at Cerner functionality and like having a person actually clicking the buttons in Cerner for accepting or rejecting a referral, we wanted to know what this team communication collaboration might look like in the future, whether, is this triage nurse able to independently triage? Would it work better if you had some sort of regular meeting, like weekly or daily or whatnot, as a touch base to talk about referrals together? And so I'm just going to hand it over to Sally and yourself, Leo, to have a conversation, just bouncing ideas. We have about, I think, 20 minutes allocated for just discussion about this topic.
Leo, for context, I connected with Sorby again this morning. We are actively putting together a briefing note so that we can create this position. And so for the purposes of the build in Cerner and inviting Marina into the conversation, we wanted to have a discussion about how we see the workflow, what the role would entail, and then we would be creating and hiring for this position for the Cerner go live.
Okay. Well, really, the process we have is already in place. It would just be somebody who's hired into this position taking over what the physicians are already doing. So what we typically have is we have a physician who's designated as the geriatrician for a week, geriatrician of the week, and that person looks at all the incoming referrals that have made it through the PA screening process. So the PA does a very initial brief screen just to make sure that the patient is the right age, they live in Richmond, and all of the documentation, like the referral form, actually has been filled out fully. And then it will be placed into a queue where it's designated as clinical review on EMR, if you're familiar with the EMR referral management system. So once it's put into clinical review, then the physician can then see the referral show up there. And then we determine if the referral is appropriate or not, and also look at whether or not it needs to be prioritized on an urgent basis or routine. And also sometimes we'll request additional information. There will be a decision if the referral is not appropriate, then we may send a letter back to the referring source and give them some direction on what is a more appropriate service for the patient. And that's the process that we have right now. So if we do hire somebody else, a nurse, to do this position, I think that they can pretty much just take over this process. But there will be some instances where they will still need to discuss it with the physician. So I think we'll probably still need like a geriatrician of the week that they'll need to discuss with us. And then they have a go-to person, like they'll know that it's geriatrician A, for example, that is on for the week that they ask these questions occasionally of.
Okay, that's good to know. And I think the reason why I think we ended up with this triage nurse role is just also from the feedback that you provided, Leo, about like the referral management functionalities in Cerner, and it's obviously not as sleek as Profile. And so kind of just trying to alleviate that additional workload from physicians, we figured maybe introducing a triage nurse would help with that as well.
Yeah, it will help take off the workload for that person who's on for that particular week.
Are we, Leo, expecting for our triage nurse to be doing some kind of intake note? Because that would be my primary question, is if we have this clinical involvement, where is this note going to be documented? Are we documenting within the patient chart, the acceptance, or declining the referral? And you know how right now there's also one additional step in our triaging is that the geriatrician of the week can also identify patients that need intake. I don't know how many we have right now, but then at this point, this would be up to the triage nurse to determine the extent of the intake. But I would like to ensure that if our triage nurse is putting in the clinical time and work, that there is documentation that it's in the health record, regardless of whether our program accepts or declines.
Mhm. Yeah, that's a really good point. I had that in my mind and I just forgot to say it. So thanks for reminding me, Sally. Yeah, this process that it does involve this decision making from the physician perspective. If the patient is more complicated, then we ask the clinicians to do an intake. I don't foresee us going back to how it was before, where every patient will have intake. I think that it would still be the way that we do things now, which is the person who's doing the screening process will determine if intake is required based on the few criteria that we have set out. Now, I don't know if this person that is doing the screening can also do the intake. That would be an interesting thing to explore. I think that would be nice to have an additional person who can do that, because from what I remember, this intake can take upwards of like 2 hours of time. So
At
it's
least.
nice to have more people to share that with.
Yeah.
Yeah, and there's a good point, Sally. Where does the documentation go? Because things are just going to be like completely different when we move to Cerner. I just,
Every interaction with the patient, we should document. It's a
Yeah.
requirement of our college.
Yes, it is absolutely required by the college, but I'm just thinking for those that we do end up declining and we generate a letter to the referring source, I would still like to ensure that, because it is a nurse and would be a clinical interaction, that we are capturing that somewhere in the referral triaging process.
yes. So
Yeah,
right now,
it has to be documented, yes.
yeah, right now the documentation is generated from EMR. Either an encounter note in EMR is created saying like, Dr. So-and-so, this patient is not appropriate for our service. Please refer here instead. Their file is being closed at the geriatric assessment program. It's either in that, if we wanted to basically freestyle the letter, but there's also a template in EMR that we created just because we go through this process so many times during a week. So it's under like a clinical new letter on EMR, and then I think it's under referrals, gap declined referral letter. So I think that we'll need to create a similar template on Cerner to do this. And then I don't know where it would show up. I guess it would be under documents.
And the same with us when we do intake and we document, but we document in Paris at the moment.
Yeah, it'd be
This
very
is-
helpful wherever we create these templates, that when the nurse generates these templated letters, that when they get printed out, it has the letterhead for our program on it already. So it should say like Geriatric Assessment Program from Richmond, and then have our phone and fax number, for example, and VCH. I don't know if that's possible or not.
Does someone on the line know if that's possible, or we can always, well, we're of course writing all these requirements down and we can take them away, but just in case somebody on the line knows that off the top of their head.
Hey, Dr. Lai, this is Jessica with Provider Adoption. I do think it's possible. I'm just thinking in the notes in Cerner, once they're created and signed, they will have a nice letterhead that displays, that facility information. My question for you is, these notes that you create for these referrals that are denied, do they go back to the referring provider and the primary care provider? Just the referring? Do they go to Care Connect?
Yeah, they would go to the referring physician, and then if the referring physician is not the primary care provider, we'd also send a copy to the primary care provider. These would be faxed, and they would not show up on Care Connect because they're not entered onto PCIS.
So
Okay, that's great to know.
I can demo something. I guess a question for the CST team here. For the document type of like patient letter, for example, is that distributed at all to the primary care provider as with other notes that are auto distributed?
Sorry, was that a question for me?
No, is a question
for
for our
us,
CST project team who are,
Okay.
but I can
Yeah.
show you what I'm referring to. So this is an example of what you could do in the future. I don't know if you can see, it's might be a bit small. Can you see okay? But what I've done is I've generated a patient letter in the system, and this is what it looks like. So it would have patient's name, it would have your clinic information, and the document type that I selected is called patient letter. And in terms of the only thing that it auto-populates is this piece up here. It says in regards to, and then it displays the patient that you're talking about, and then you just type whatever you want in here. And you can create templates in Cerner that can just, you can use the templates in here. Is that what you're kind of looking for?
Yeah, yep. We'll just need some training on how to actually
Do it.
get to this. Yes.
Okay, we can do that. I know, Dr. Lai, you're a little bit more familiar with Cerner, and later on we'll provide a kind of a more thorough demonstration. But in case you're wondering how I made this letter, all I did is, are you familiar with like the message center and this button up here called communicate? I just went and clicked on a message, and sorry, actually no, I didn't. Went here. Just close this. No, I don't. Yes. So I went here and I made, are you familiar with these drop downs from your use of Cerner?
I used the message, but no, not the patient letter. That's new to me.
So I can pick patient letter. And so what I did is I did that, and then I changed this and I just did patient letter. And then by doing that, that's how it had that in regards to, and then the name. That's what came up. And then I just you just type whatever you want. That was my test. That's all I did. And then you can, are you familiar with auto text? Like if you do like comma, and you can create, and then you can use templates like that in here. And you can share your templates with other people.
And if somebody works at different clinics, like myself, I work at St. Paul's and here, how do I select the appropriate letterhead then? Like, how do I make sure that it's not going to select the St. Paul's letterhead?
You have to make sure you're on the right patient encounter. like the location. So as
Okay.
long as you're on the right patient encounter, it will print whatever is here.
Okay.
Yeah.
And then once that's created, then does it get saved somewhere so that he's
Yep,
it's
it's
right
right
there.
here.
Yeah, I see
Yeah,
it.
so it
Okay.
gets saved here. And then once you save it, you also have the ability to fax it. So what I did is I right clicked, hit print, but instead of like selecting a printer, what I did is I did manual fax, and then I just put the fax number of where I want it to go to.
Okay.
Yeah.
Thanks.
So then it gets faxed out directly from Cerner, and our program support would not have to go over to a fax machine.
Yes.
Wonderful. Quick question about the letter. If it's generated through Cerner, does that mean then it will be in the system, like kept in the system even after we fax it with the health record? And so technically there should be a record of any documents that we've released.
That's correct.
Beautiful. Okay.
If it is in your process, like I wasn't sure if the physicians or clinicians always wanted to do it themselves, but there is a workflow where you could document the patient letter and then you could send it electronically to like a clerk in their message inbox. And then from there, they could fax it on your behalf. But if it's more efficient to do it yourself, you can just do what I just showed you.
I think that would be dependent on whether the fax number is readily available. So then would a patient's family physician information be in Cerner, and would that be auto-populated, or would we be needing to actually manually input the fax number?
You'd have to manually input the fax number. That is one of the things that Cerner doesn't have is saved fax numbers. So you'd have to remember what it was. So if that is a challenge, then the workaround is that you could send it to a clerk, and the clerk would fax it on your behalf as well.
Yeah. Marina, what do you think in terms of referrals and a triage nurse? Should we be involving program support with faxing out like an acceptance or decline letter, just because it sounds like our clerk will still need to book the appointments for folks that we are accepting, and we'll need to close. I think in the workflow it had said close referral encounter, and so potentially that will just kind of close the loop, right? If our nurse told our program support that the referral has been declined, and then part of the discharging the referral encounter includes faxing out the letter.
Yeah, I think it would be the better way to do it.
I just want to make sure that the communication is tight.
Yeah.
So I can quickly show you, Sally and Leo, since you're a little bit more familiar with what the option 2, which is like leveraging a clerk to help support, is that when you are here, and let's say you want to do a patient letter again, and I want to do this, I type blah, blah, blah. And then instead of hitting print now, I just select do not print now. And then you can search for the person that you want to send it to. So if I'm going to put this person here, click OK, and then I'm going to hit done. And so then that is it's also saved to the chart. So it's here now. And then if I log in as that other person, it shows up here in the patient letter. And then if you open it, this is where it is. And then the clerk, for example, could then just say, yeah, I want to print now. And then they could then use like the faxing functionality from here. So if I click OK, you can either print it, or you can go into the chart and you can e-fax it from there, or fax it from there as well.
And Sally, to
Here.
note, I think Fraser did put in a chat, these patient letters do distribute to Care Connect and Accelerus. So
Yeah.
even if we don't manually fax it to the primary care provider, if they are attached, then it will automatically distribute to their accelerators.
Do you think this would be your workflow here? Is like physician creates a patient letter, they then like send it to clerk sees it in here, and then they would just fax it out themselves on behalf, or
The vast majority of the time, it's the family physician who's referring the patient. So if what I just heard is correct and it gets sent
to Care Connect?
to Care Connect and it gets copied to the family physician, then we won't even need to fax it the
Okay.
majority of the time. But how do we make sure that their profile on Cerner is actually attached and that it's actually going to be sent to the family physician?
When you register the patient, the clerk will just need to fill in the appropriate fields. So I'm just opening up what it sort of looks like in here. So if I click on this tab, it's got admitting, attending, PCP. This is a primary care physician right
Okay.
there. So just
Okay.
ensuring that that's accurate.
And it sounds a whole lot like the process, like this patient letter is very similar. If it's going to show up on Care Connect to me creating like a consult letter after I've seen the patient. And when I do that on Cerner, I know that just before I send it, before I submit the letter, it lets me put in like all the physicians that I want to copy. And these physicians don't even need to be like using Cerner. They can be external providers. Is this
Yep.
similar that I could add somebody? In that case, I wouldn't even need to fax it then.
So I think it's just the templating, but like if you wanted to make your own note, you could just make your own note and do it like the regular way. So let's just do like general medicine clinic note or some other note, and then you would just do it as per usual. And then when you hit sign submit, this is probably what you're referring to. You just enter in all those different names that you want to send it to. Yep.
Can the nurse do this though, or is this a screen or a process that's limited to physicians?
No, the same box pops up for a nurse. It's just the nurse doesn't have access to, well, I guess the nurses should only be using like the nursing specific note types.
Okay.
Like some of these are meant for just physician use. That's the only thing.
Okay.
And what?
But Polly, I think we submitted a request to have a nursing note actually go out to Care Connect, correct?
Yeah, the clinic notes. But I saw under the type, it does have patient letter, like it's a letter patient
Yeah.
actually. So you can actually do it here too. So
Yeah.
it's the same workflow as your consult letters.
Yeah.
And Janice, I just wanted to point out as well, there's also the provider letter. So if the intention of this letter is to go to the provider and not actually go to the patient, is using the provider letter okay as well? It has the same distribution properties where it still goes to Care Connect, the primary care, and the referring. And you can see those when you're submitting your note.
Yep.
You don't have to include them, but okay.
So there you go. Okay, this is the pop-up box for the provider letter option, so same functionality.
So the nurse would have access to the provider letter?
I'm gonna just test it out. So I'm logged in as a nurse right now, and if I go to the same button, I have the same thing.
Okay.
All
Because
the
I guess I just don't know if it's an issue for nurses to be creating provider letters. Like that's I don't know if that's a process thing or yeah.
I think the verbiage is a little confusing too, because it almost seems like this letter is for a provider, not necessarily from a provider, but you're picking the provider recipient. Yeah.
Yep.
Quite often we send letters to like if we require more information, like we didn't make decision yet, but we require more information. those letters, how they're gonna be made, and are they gonna be put in Care Connect as well?
Yeah, so Cerner has the ability to have things distribute. I think as we, go through your clinic's process, we can just teach you how to use the system to do your day-to-day work. I'm just mindful of the time, and we have Leo, you only here until 2:15. So there's a few other questions that we kind of needed your input on before you left for the day. And then the afternoon, Marina, we have dedicated time to do like a full demo so you can see like all the things that Cerner can do.
Talking about intake process now. I'm not talking
Okay.
about just general letters.
Okay.
So
Is-
Marina's
is the-
referring, sorry, to the intake workflow. Sometimes between the program support and the triage nurse, we anticipate that we'll be needing to connect with the referring source for more information.
Mm-hmm.
Like Erica, all those pieces where we had talked about what is required, like consults, diagnostics, or even just labs within 6 months, those are the things that we will need to communicate with the referring source during the triage intake process.
So what I'm hearing is if the referring provider submits a referral to you, but it's incomplete, what do you do? So we can show that there is a process, like the nurse can, if you need to, like send an electronic communication order to the clerk to say, this is incomplete, I need more information, and the clerk can help reach out and gather those pieces of information to complete your referral, if that's what you want your process to be, or the nurse themselves can just reach out and get what they need to do, and then proceed with documenting their intake note and then going from there.
Right now, our program support actually already will ask for additional information at time of we receive, part of a referral package, even before it gets to the geriatrician of the week. We kind of have these incomplete referrals, and there may be situations where our nurse might be asking for program support to obtain additional information.
Mhm.
But we could chat a little bit more about how it's organized, but we would absolutely want to make sure that the workflow is clear where these buckets are, because there are referrals we get that are incomplete where the program support is asking for more information. Then it will go to whoever's triaging, but potentially during the triage process, if it's a very complex patient, we also may be asking for additional information at that point. Or depending on my next thought too is, given that we have a wait time, potentially, especially if we have a triage nurse, our triage nurse may also be providing recommendations if we decline a referral and we're not appropriate service about other resources, or if somebody's waiting for a referral, potentially our triage nurse would be recommending things to do in the meantime. So we just wanted to make sure all that can be communicated and documented.
Yeah. And so I'm logged in as, I'll just show quickly now, I'm logged in as a nurse again, and I'm on my referral triage page that I can use to like view information. So you could, if it's your process, just document a note because you're responsible, you need to do it to have some sort of record. So you can say like, referral reviewed, but XXX documents are missing, need to follow up with referring physician, for example. And then when you hit sign submit, what you could do is you can always send a copy of this to the clerk's inbox so that they know exactly what's going on, in addition to sending like an electronic communication order, which I can show you later on today. But that's one way of communicating too. Do you think that would kind of meet the requirement of what you're trying to do, is like put some documentation, but then send like a sort of like a notification to the clerk so they know exactly what to reach out and get for you?
I think that would work, Marina.
Yeah, probably. Like, it's really hard for me to say right now.
Okay. All right. Well, we'll move along with the other things that needs Leo's input, but that's just my thought, right? If we're looking at how we can improve what we're currently doing, just because with profile, yeah, our PA is holding incomplete referrals until we get all the documents before putting them into clinical review. And it's been kind of messy trying to make sure we have all the complete referrals for review.
Okay. Yeah, so I am going to try this. See if it'll work. Okay, so I wrote a note as a nurse. And if you want to see where it went, it's here. So I wrote my note. It says referral follow-up required. You can call it, whatever you'd like. And it's now here. But then you know how I put a name in that box? Now if I go here, it should show up here. So you could, instead of putting the physician's name, you could have put your clerk's name, and then they would see it here. Referral reviewed, but XX documents are missing. So that's where it could go as well in terms of communication. Hopefully that makes more sense. But I will stop sharing. And I know that we have some specific things, Eric, you wanted to kind of ask while we
Yeah.
have Leo's attention.
Yeah, that would be great. I'm going to share screen again, and I was having issues with my audio, so I turned my camera off. But if all of a sudden it becomes difficult to hear me, do let me know straight away. Can you see my screen again?
Yes.
And so we've got 25 more minutes, and we've got some validations to go through for design. And some of it, what we can do is, Sally, Leo, Marina, we can send it to you over email so you can take a closer look after this session. I'll just kind of explain what the pieces are, and then we can get feedback that way. Because I also want to make sure that there's space for any questions, Leo, that you might have, because I know you emailed things over this morning. Does that sound all right?
Yep.
Okay. Okay. All right, I will try and go through this quite quickly. So looking at gathering some clinical requirements today, we wanted to talk about referral templates, and it does sound like the triage nurse process will work for your group. And it sounds like there's some good ideas to learn from what's already happening in Profile EMR to get some templates happening in Cerner for you. So we wanted to talk a little bit about providers that are going to be referring from other Cerner sites. So this is what the referral order would look like. You've seen this before, probably, Leo, so I won't spend too much time on it. Essentially, there'll be a pop-up that shares all about the GAP program and what it does. And then there's, of course, the auto text. This is just a sample from someone else. But Sally and I have been taking some time this past week to generate just a mock-up of what your auto text may look like for GAP. So we do need, Marina, Leo, we need your validation for this. What we can do is email it to you so we don't take too much time during this meeting. Does it sound all right?
Mm-hmm.
Yep.
Okay, and mostly it's your fax referral form with some updates from Sally, I think. And then there's this auto text that the provider can then use to fill out information. So we've mocked that up as well of what that could look like on the next slide. I know it's kind of tiny, so I've written out the questions in a Word document as well, which I'll go to on the next slide. But we will send this to you as well for your validation. And essentially, we took all our inspiration from that fax paper referral form. So just taking those questions and putting them into the Cerner system. Does
It
having
looks like
auto text?
sorry, Erica, a lot
No,
of
go
work
ahead.
looks like it was put into making this template already, but we updated the referral form
Oh, you did?
Yeah, we didn't roll it out yet,
Oh,
but
okay. Tell us more.
uh,
We're just learning, so we're happy to try again. So we're excited to hear about your new form, or I should say, I'm just learning. So happy to hear about the new form. And
that's
do you
really
think it could go into Cerner like this? I was really into these yes, no drop downs when I saw it.
yeah. I think it could. It's a little bit.
Okay.
I can share screen, Erica. I have a live one on my side here.
Mm. Mm.
Okay, I'll
Even
just-
better.
Okay. So what I'll do is actually delete this. So what we did is, this is the auto text that we just mocked up, or I should say Fraser mocked up. Thank you, Fraser. And then in terms of the yes, no, so for cognitive decline, it's yes, no. If anyone actually documented any of these scores using one of the like forms in Cerner with discrete data, it can pull that score here. And if no one documented anything using those electronic forms in Cerner, it'll just say no qualifying data available, but you can always delete and put a number in here instead. Functional decline, yes, no, yes, no, yes, no. But yeah.
Sorry to interrupt. So I don't think it'll be an issue in terms of getting the form translated onto Cerner. I think it
Mhm.
should be doable. It's just that I just recognize whoever translated the form already, they'll have to do it again for the
Okay.
new form that we have. We just modified a few things. So there's, for reason for referral, we no longer have these like check boxes anymore because we found that people were just checking something off and then they wouldn't provide a reason for referral. Like there's no text. So now instead we have a text box that they just fill out the reason for referral without doing any check boxes anymore.
Okay.
And
So like
there's
that.
several other modifications.
Okay. Yeah, if you want to send us a copy, we can get working on that.
Yeah. Thanks again, Fraser, for your support with that. And Fraser put a comment in the chat that it's no problem to get the new one mocked up. So we'll mock it up and then we'll send it to you along with the other form just for a final validation over email. So you don't have to sign off on it just right in this moment.
Should
Sound
I send
okay?
it to you, Erica?
Please.
Okay.
Yeah, be great.
Quick
My last
question,
name's Norman. Yeah, go ahead, Sally.
Quick question. So the part that I validated was the first part of like what our program is about. And Leo, for context, I actually did take it from our new referral form. I just didn't see this part of the mock-up yet. But Janice, what you just demoed, that description, program description didn't show up because then my thought was that the referring provider that's internal from Cerner would first see that information before it goes to this, what you just showed? Or how does that work?
So to do a referral from a physician that's using Cerner to your clinic, instead of using like a piece of paper, filling it out and faxing to you, they could place an electronic referral order to you. It's a two-step process though. And so step one is they place this electronic order, and that's when they select it, that box just pops up in their face. They read it. And then in that pop-up box, there could be an instruction to say, you need to also put in a note chart a note and use this template that I've made. And they would copy and paste that template, the comma, RHS, and then they would then create a note in Cerner, and then they would fill out the template that whatever you wanted, and they would hit sign, so that when the referral comes to your clinic as part of the referral triaging process, your future triage nurse would go into the patient's chart and look up that note that was documented by the referring physician. And that would be that's the whole workflow.
Okay. Does that make sense, Marina and Leo, later when Erica sends it? So the previous slide with the gap, this info, the reference text that I have validated, that will be the pop-up for an internal referring source. And then once they've read it, then they can proceed with the referral order. And the referral order, we'd like to be in alignment with our updated referral form. Yeah, okay.
That was a beautiful summary.
Okay,
Thanks,
just because I
Sally.
wasn't
You
sure. I was
got
like, I
it. You
thought
got
it was
it.
that text. Okay.
Yeah. So there's two. Yeah. All right. We're just about at 2 o'clock. So I'm going to speed us through this. There's the old paper form. We wanted to validate a few design pieces around encounter and medical services. So my colleague Andy is on the line. Andy, can you help us through these slides really quickly so that we can save some time at the end for questions? So we're ending at 2:15, but we probably want to end this portion around 2:09.
Yep, I will quickly walk over these few slides, and if there are any questions, please feel free to let me know. So quickly, we'll just quickly talk about encounter types. So just as a summary, an encounter in Cerner is any single patient interaction or any specific visit to the health organization by a patient. So these interactions can include, but is not limited to, for example, like a patient visits, any residential admission, specimen examination, walk-in visits, phone calls, etc. They're not limited to any type of interaction, but all of these interactions do need a Cerner encounter in the system. So given that I think we have a basic understanding of how your clinic works, and based on just kind of the frequency that you see your patients and your patient population, we have decided that the recurring encounters seems to fit your clinic best. And just to quickly talk about the recurring encounters. So like I said earlier, how every every interaction needs a single patient encounter in Cerner to reflect that visit. What the recurring encounter does is that it actually enables you to associate multiple visits to one single encounter in Cerner. And that just means that the patient would basically be going under a short-term or long-term or continual kind of visit with the clinic. They're going to be an active patient. You know that the patient is going to have this defined series or length of time that they will be seeing your clinic. And that allows you to book all appointments and all orders and every documentation all on that one single encounter, rather than having to create separate encounters for each time you see the patient. So a couple things to note, just important pieces to keep in mind. A recurring encounter is appropriate for use when there is a series of outpatient appointments that are scheduled for the same reason. So for example, the patients are all coming in for one type of visits, one reason, one location, etc. There's a defined cycle of outpatient appointments. There are 2 or more appointments within this general series of appointments. And one thing that's really important is that there are no more than 28 days or around 1 month between appointments. So that means that at minimum, you're seeing the patient at least once a month. And then finally, Cerner scheduling is also a requirement to use the recurring encounter. Are there any questions at this point in time? Does this encounter type sound correct?
Well, there is typically more than 28 calendar days between appointments. So I don't know if that would cause any issues with selecting this type of encounter type.
So how long kind of would you say are these frequencies or intervals between appointments?
Could be, 3 months, 6 months, 1 year. It's usually
Okay.
not within 1 month that we follow up again.
And would this also include like not just physician follow-ups, but like maybe follow-up appointments with allied health or nursing? Would they be seeing the patient within 28 days?
It's variable. But I would say it's very often that there's more than a month in between encounters.
Okay.
Okay. So then if that's the case, like the other type of encounter is obviously it just automatically discharges at midnight. It's called an outpatient encounter. So
Yeah, so yeah, the other option would be just to basically create an encounter for each time the patient comes in, and then that would be like a separate encounter that you would be creating for those patient visits. Given that you don't really know if it's going to be within 1 month or that kind of frequency or interval time, does the outpatient encounter strategy then sound more appropriate?
Yeah, you'd have to tell me because I don't know what that
Right.
is. I'm not sure.
yeah. And I
Yeah.
think just in the interest of time, now that we understand the frequency of appointments, we can maybe loop back just because I think it's more of a clerical workflow with them knowing what
Sure.
encounter to select and how to book the appointment.
Mhm.
There was just a few other things that we needed your input on, Leo. One was the medical service, whether or not you wanted a clinic flag for your for this clinic, and what your process is in terms of like ordering lab recs and whether or not you always hand it to the patient in person or if you have a clerk fax it. So there's a few other things that we needed your input on, but let's start with medical service. These are all the different types of medical services that are available in Cerner. It's a very long list. We made the assumption that the most appropriate one would be geriatric medicine, but we wanted to confirm if there was anything else that we should consider as an available option when your clerk registers patients.
Yeah, that seems to be the most accurate. Yeah.
Okay, and then the other piece was the clinic flag. So are you familiar with the clinic flag functionality with St. Paul's, with the
Let me
Cerner bill
just
at
read
St.
this.
Paul's?
Used in CSU stereotyping.
Essentially what happens is if your patient is admitted to a hospital that's using Cerner, you get notified.
Oh, I see. Oh, no, we don't use this at the clinic that I work at, St. Paul's. We don't use this.
Okay. Do you think this would be a benefit for GAP though?
I
We
think it would be
assumed,
helpful for the allied health. The physicians typically don't really need to know this. I think it'd be nice to have, and like a nice to have feature.
okay. I see Marina's head nodding.
Yes. it would
You'd
be
want to
good.
know. Okay. So we can build one and then we can review the three different ways you can get notified. So there's some options that we can review later on in the afternoon. The next one is requisition manager. So we just want to understand when the patient comes in, visits you, what is your general process? Do you usually like write a lab rec and you hand it to your patient? Do you usually have your clerk like electronically fax it to Life Labs? Because there's some options of what we can do in Cerner.
I leave it up to the physicians to decide how they want to practice. So everyone has a different practice process. Some people will print it out. Some people will fax it directly to Life Labs. Some people will rely on the clerks more heavily. We have 4, 5 physicians right now. Yeah, so we each have like different practice processes.
Okay. There is newer functionality in Cerner that is being implemented and fingers crossed it's going to be available for when Richmond goes live. There's something called Requisition Manager, and essentially if you opt in, then you have access to the ability to e-fax your lab recs to Life Labs. And if you don't opt in, then that ability to e-fax is not an option. The downside of opting in is that if you were the type of physician where you would want your lab rec printed so you can hand a physical copy to your patient, it's a few extra clicks. It doesn't automatically print once you hit sign.
Yeah, I don't know. I'd have to see it to make a decision, but I guess are you saying that we need to make the decision and then like right now, or?
We have more sessions with you, so you can definitely take this away, think about it, and then just let us know if you're opting in or opting out.
Okay.
Can I ask one more question that might help Leo make a decision? So with these electronic lab recs, is it to a specific location or is it to like Life Labs in general? So the patient and family would be able to choose a location of their choice.
Similar to the thing that I showed you where you can like fax the document, a little window will pop up and then you put in the fax number.
So then is that location specific or general?
Like you would need to tell Cerner where to fax it to. So you'd put the phone number in, or the
I
fax
see.
number, I'm sorry.
Okay. So it's not like Life Labs e-requisitions where it's basically like an email that kind of can be accessed from any location.
We can show you what it looks like. It's just basically it just once the physician hits sign, instead of printing, it goes into like a list, and the clerk monitors like this list, and then they would see it, they would click on it, and then they would say, I want to fax this to someplace, and they would need to put the fax number where it should be faxed to, for example.
I see. Okay.
Okay. So no decision today. So then the next one we wanted to review was
I wonder if we defer these ones, Janice, because we're maybe looking at a
yes.
different encounter type strategy.
Yeah.
And I have, let's keep going.
Yeah, do you have the follow-up appointment slide for Dr. Lai?
I don't. I had moved that one to the second half.
Okay. We can just get your input. I don't know if you were able to tell us right off the bat, Leo, but in Cerner, there's a way for you to electronically communicate with your clerk or your program support, like to say, hi, I want a follow-up appointment with my patient, and to send that information to your PA. And so we were just wanting to, if you wanted to provide some input into what the name of that appointment should be, like follow-up, assessment. I don't know, Eric, if you're able to show
Let
the
me see if
list.
I can travel there now.
Okay.
Just stand by.
Do you use the follow-up order functionality at your St. Paul's clinic, Leo, or is this new for you?
Yeah, we don't really do that many follow-ups there. If I'm being honest, I usually just send an email to the clerk at St. Paul's if I need follow-up with a patient.
So this is a better way to communicate because it actually is less work for the PA. They don't have to then manually enter in all the patient demographics and location. Like it's a lot less work. So what you would do is, this is what it looks like when you place the order. It's called follow-up clinic, and then it would be your own, it'd be GAP. And then you see that box where it says appointment requested, and it's a yellow box. It's a mandatory field. So if you opened up that drop down, you'd be able to select like nurse follow-up, social work follow-up, MD follow-up, or if whatever option, whatever makes sense for your clinic would be in that drop down, so that when it goes to your PA, they know that I need to book an appointment for the PT, or I'm booking a follow-up appointment for the nurse or Dr. Lai. And so that was the purpose of this portion of the session, is what do you want in your drop down? What do you want the names to be called?
Yeah. Yeah, it would either, it's really the follow-up is the main thing is like how much time to book for the follow-up and also when to book the follow-up. Those are the two main things. Like right now, the physicians are majority of the time, we just give the appointment to the patient. We look in the EMR ourselves and we book the patient directly in, because that helps to reduce the, there's been some issues with no-shows when we rely on the clerks to do the booking for the follow-up. So we try to get the follow-up appointment booked before the patient leaves. So ideally, like now that the physicians, I'm hearing that the physicians might not be able to access the schedule and book the patient, their follow-up at the time that we're still seeing the patient. So if we're relying on the clerk, then I want this order to go to the clerk, and then the clerk, I guess at the front desk, will need to catch the patient before they leave and then give them the appointment. So all they need is when to book the appointment and how long, the duration of the appointment.
So the how long, like we can preset in the back end. Like if you select this option, it equals, 60 minutes duration, for example. And then in terms of like specific date time, you can put that in the special instructions box right there to say, I want this appointment on November 3rd at 1 p.m., for example.
And just to jump in a little bit, this is Cynthia from the scheduling team, because I would jump off this order and I'll be creating the appointment types. So let's say you had a geriatric new appointment, or I'm sorry, it's a follow-up, a geriatric follow-up, and in special instructions you put, with Dr. And then for 45 minutes, that the scheduler can then pick that up, and even though we'll default the duration maybe to 60 minutes to start with, they can change it to 45 and pick the correct provider. So if it's a nurse, if it's an OT, whoever it is, they can go ahead and just plop that in based on your notes in the special instructions.
So yeah, if it's default 60 minutes, you can say, I actually need 45 minutes on November 3rd at 1 o'clock, for example, and the special instructions. And Cerner does have automated appointment reminders, so that can also, you can help remind the patient as well.
That usually helps with the no-shows.
Yeah.
I would just say, like, for the appointment requested, just make it really simple, as in like
Okay.
MD follow-up.
Okay.
Or like MD new appointment. And then the visit modality, I'm not sure if you can put like things like home visit or not, because sometimes we'll request that we need to see the patient at home.
Those are hard-coded, the visit modalities, but there is in-person offsite. There's not home necessarily, but in-person offsite usually means home. So you just put in-person offsite, and that would relate to your home visit.
Okay. So those are
And
hard.
can I ask, when you say MD, the appointment requested MD new, but do you ever have, are there patients following up with your OTs, your nurses? Are they being scheduled as well for follow-ups?
It's not the physician that schedules those ones. If we need the patient to see the nurse or the OT, we'll make a referral to them by sending a task in EMR.
Janice, will that continue? I'm just trying to figure
No,
out.
it's not. Erica, I can just show screen quickly so they can see what the drop downs are.
Absolutely. I'll stop share.
Okay, so this is,
go ahead.
Yeah, so here is an example of what we made for VGH diabetes. Like they have new follow-up, just very basic for all their different roles. And the visit modality is data, email, in-person clinic, in-person offsite, phone, text messaging, and then these videos. So if it's a home visit, you could do in-person offsite.
Okay.
And then here you could say 45 minutes, or sorry, not 45 minutes on December 3rd at 1 p.m. And then that would go to the PA.
And I can definitely build all those appointment types for you, but if you were leaning towards, you kind of mentioned just having a very generic appointment type. So if you had one, and this was tied to again, like we have a geriatric follow-up appointment type, then you would have to state in the special instructions who they are coming to see. Because that's not indicated here. You wouldn't know if it was the OT, the nurse, the provider, whoever it is specifically. But you can put that in the special instructions. The more specific you are with the appointment types, such as the OT, again, like the nurse provider, then that's less for you to have to update in the special instructions. So it's really just how you want to arrange it.
Okay, yeah, I think it
And-
would be important to just say geriatrician follow-up then
Okay,
for appointment requested, and then all the other details can be put into special instructions.
okay, we can definitely do it that way.
It's 2:18. I know that you had to leave at quarter after. There was one other piece that we wanted to cover, but I don't know if you're able to stay for another few minutes or if we should cover it next time.
I can stay till around 2:30.
Okay.
I'll have to leave around 2:30.
So the other piece was just around referrals amongst team members. So for example, you're seeing a patient and you think that they would be a good candidate to be seen by your PT, for example. What is the best way of communicating that request? So option one is to use the message center functionality that I showed you earlier, where you can be in the chart. Hang on. You just get rid of this. So just you can either send a direct message to a person, and then they can receive a direct message from you to them. This information though is sort of like an email. It's not saved to the patient chart or anything. I have seen some clinics use this and they create some sort of standard template that maybe perhaps their allied health professionals, want the physician to follow. And then option two, which I've seen and is used in many other clinics, is that when you go and create your note, sorry. Yeah, just do a note. And you do your note. And after you do your note and you hit sign, you send a copy to the person that you're wanting to refer to. So in this case, if it's your physical therapist, you could put their name in here. And then maybe as part of your note and your the plan of action for your patient is like refer to OT, then that note would not only get saved to the chart, but a copy of it would be sent to that person's message center, and then they would be able to review the document as well. It's just, so I didn't know what would work better, if the direct message to message would work better, or this process where you're documenting a note and then sending a copy to the person that you're wanting to refer to within your clinic.
I think it seems a little bit clunky either way, because with the first option, it's not saved to the chart, which I don't think that would be a good idea. I think we need a paper trail of these referrals to look back. The second option, I don't think is good either, because it's going to include a lot. The whole consult note will be there, and then they'll have to just look at that one area where it's like the referral. Like, it's going to be a lot of
Okay.
reading for the clinicians to just get that small amount to figure out why we're copying them on the letter. So I don't know if there's another option where we could just.
There's a
Yeah,
third
okay.
option.
Okay.
So you can send it to a person and then you just click save to chart. I'm assuming that the best option is general message. So is anyone from CST able to tell me that this is not okay? But I'm going to do it. Okay. And send. So so here it just shows up as a general message as the subject and the type of note type. So it just says general message with patient information, and then it's saved to the chart here. And then if I log in as a physician, just try to find my screen, it should show up in here as well because I've sent it directly to you. Is that a better option?
It seems, yeah, better than the other two options. I'm just
Okay.
wondering like what the what the thread will look like. Say if I want to just, is there like a back and forth dialogue that you can open up and just see everybody's like messages? If I'm like messaging Marina about this patient, it goes back and forth, and there's like 10 messages.
Yeah, I might just show you. Let me, if I go to my message center, so if I go here, and then I want to reply, test reply from physician. So you can see that what you wrote is here, and then you hit send, and it's sending to that person again.
Mhm.
And it's also saving to the chart now. Then if you go to your sent items, it's like you have you always have a copy, like a sent items folder, like in Outlook. And if you go into a nurse, you should now see this thing in here. So I'm back as a nurse. And then here is the thread. So test reply from physician. And then now you can reply, replying back as nurse. And it just keeps going.
Okay.
And I can
And
hit
then
send.
if you go back to the patient's chart, then all of these messages show up under documents.
Yeah, so then now if I go here and I hit refresh, it's actually I didn't realize it just amends it,
Okay.
so you don't have like 1,000 general messages. It's
Yeah,
just
okay. That's good then. I think this should work.
okay.
I don't know. Marina, do you think that this will work?
I think I missed the last part, like what we were.
Okay, it's just this is for making referrals to clinicians from, I guess, the physician, but even if you wanted to refer to Ed or Lily, OT or PT, then you could also use this function and just create a message
Yeah.
and then click the save to chart so that it actually gets saved to the patient's chart. And then if we have back and forth messaging about the referral, then you can reply in the message and it all gets saved to the patient's chart, just like this example.
Is there a possibility to reply to a few people or just to one person?
No, you could add as many people as you want in that to box. I just did one person as an example. Okay, so we went with a third option, which is a hybrid of the two. And I think that was the last thing. I'm just looking at your list of discussion points, Dr. Lai. I think we covered everything except for the appointments. So understanding that, physicians don't have the ability to schedule, I think the only way to kind of create time blocks is if there's some sort of communication with the PA to block time in the scheduling book. But Sally, I don't know if you've been brainstorming ideas about how to block time and knowing that like Leo's gonna go on vacation the month of April, like don't book an appointment with him.
Yeah, I've been thinking that that's probably all gonna have to go through program support, right? Because it would be through registration and scheduling and how we would be able to communicate that, or even what Leo was saying earlier about follow-up appointments. A lot of times it's helpful to hand the patient and family an appointment before they leave. And because we don't necessarily have a front of house PA that would be able to capture the family, some of our physicians, and I'm thinking Becky in particular, will offer an appointment, support the client to input the appointment in their phone even before they leave, right? And so then how do we communicate those pieces to our program support? And what would be really helpful for our physicians is that they need to have access to a live schedule. So for example, if Leo's 1 p.m. patient was offered an appointment, before the 2 p.m. patient leaves, Leo will need his schedule updated with, any appointment he would have offered to his 1 p.m. so that he can offer his 2 p.m.s an appointment slot. So I think we really need to buff up our program support because I can't see any other way of making it work. That's my thought of what I know of the system. But
Yeah. And so in terms of live visibility, this is what it could look like. This is very busy. This is a VGH diabetes clinic. And so what I've done is like you can actually look at anybody's schedules, in fact, here. And I just search for this, and then it shows you all the different resources that are available. And then these are the time blocks. And so right now, the only appointment that I've booked is myself for today with a social worker at 3 o'clock. But then if you had multiple, you'd see them all across the board and you'd be able to see what was available.
But I mean, what, like, when we were discussing the referral, the follow-up referral, until the program support actually inputs it, when our clinicians look at the schedule, that AM test wouldn't show up yet, right? So
That's right. So you'd have to put it in and
yeah.
then hope that no one else takes that slot.
Right?
And
Or it's
yes.
even if, say, Leo offered somebody that appointment, say, I don't know, our program support was trying to rebook somebody because they phoned to change an appointment. We need to make sure there's no double bookings that way.
Mhm.
Because right now our physicians and clinicians can just put it in the minute they offer the appointment. So that is where I've been thinking about it a lot, but I don't have any brilliant ideas.
Yeah, I think the only way to really mitigate the risk of the double booking is if there is a patient that wants to rebook, having a process where you just don't rebook without looking at all the requests that are coming in, which I don't know how easy that is to operationalize, but yeah, that's the only thing I could really think of.
Yeah. Can we table that as a risk? Like the double booking, just because I'm mindful that our program support hours are also within
Absolutely.
office hours too, right? Those would be the same hours that our physicians would be seeing patients. And so, I don't really want to hold for rescheduling to be the end of day. And then by then our program support is also gone. And then,
Yeah,
of
for
course,
sure.
phone
Yeah.
tag happens. It's sometimes really difficult to reach caregivers to sort through appointments. So whenever a caregiver returns a call, we try to offer in that moment while we have them.
Yeah. For sure. And
Yeah, absolutely. We can table that.
yeah. Okay, it's
We are
2:31.
at 2:30,
Yes.
everyone. Yeah.
Yeah.
Thank you, everyone. And thank you for staying extra with us. We really appreciate your time today. And we will be in touch because there'll be lots more follow-up and we look forward to collaborating.
Okay, I gotta sign off now.
Okay.
Thanks
Okay.
for your help. Okay, thanks everyone. Bye.
Thank
you,
you.
Leo.
Bye.
All right. Our next portion, I see Marina Jin has popped into the room with you.
She just left, but she will be back.
Okay.
She's here with me.
And then I see Ed's on the line too, and I see Sabrina's on the line. I don't see Cam. Let me just text Cam.
While you're doing that, Sally, Eric and Janice, I am here in the office at 6:01, but I seem to have an unstable internet connection. But I didn't want to log off during that last portion because I didn't want to miss anything. And I also know that I have the PowerPoint up. What are we thinking? Is it okay if just when it gets unstable that I turn my camera off, or because we're
Yeah,
not going to have a
turning,
break for me
yeah.
to, yeah, I'll just turn it off then. So if my camera's off, that's all that's happened.
Okay. So should we wait a few more moments, Erica?
In the interest of time, I think maybe it'd be good to start, just because I'm mindful that Cam does have a huge portfolio and I'm happy to catch her up to speed later, but we've got Sorry, no, Marina, Jin's not back in the room with you yet. Okay, let's hang tight until Jin, because I don't see her in that chair.
And Janice, I wonder if once we get through the intro bit, if we dive into the demo, and while you're doing the demo, I can log off and back in because Eric's a co-host. The meeting should stay stable. That work for you?
Mhm.
Okay, perfect.
Marina, while we wait, I know that we sort of dove right into showing you things in Cerner without really giving a nice overview of how it all works. Was there anything in particular that you saw today that you want us to re-review and kind of explain in more detail this afternoon?
Be honest, everything, because like, you know, it seems so unfriendly, so difficult. Yeah.
Okay.
Okay. That's
And
really
rest
good
assured,
feedback. Yeah, we love candid feedback. Thank you.
it is a lot. And rest assured, you're not expected to memorize everything that we showed you today. You will have lots of
Hope so.
training next year. Erica will be there with her team.
You which way? The screen? I think you can see here. Yeah. I kind of logged in there. I'll just turn it on.
Sorry, while we're waiting, one more question. Is today the time we're also going to chat about Paris profile, Cerner, and what that transition will look like? Because I'm pretty sure that's going to be a burning question from my team. So just throwing it out there. Are we including that in today's session?
We didn't have it officially on the agenda, but we can definitely make space. Was there like specific questions or things that you wanted to talk about about the transition?
Yeah, like what the plan would be, whether it would be because we had hoped to come off Paris first, because right now it's a lot of work for program support to register and log referrals in both Paris and Profile. And so initially we had planned for the Paris piece to end this fall. And I'm just mindful that the longer we delay coming off Paris, the more referrals and mistakes there will be in the system, because right now there's a lot of confusion in our workflow of referrals that get logged and then when they get discharged. And so I was just wondering if it's a cleaner move. But also I think the team would probably like to know what the transition plan is, because the multiple systems has been super confusing.
Yeah.
So
Yeah.
knowing that Cerner will be a learning curve, I want to ensure that we give the team the best chances of making the most successful. If it means coming off one system in advance, I think we should at least discuss it. Because there's a lot of steps, right? And there is the learning piece. And so I just want to know what the transition plan is.
Thank you, sir.
Yeah, and I think the last plan that was discussed amongst like your leadership team, which includes Sarbi, the senior medical director, Dr. Aleko Alexiadis, as well as Joanne, the VP for community. The decision at that level was to wait until Cerner comes next year, which is supposed to be late spring, early summer, and that we would just move anyone that was on Paris for documentation from Paris onto Cerner. And then for your physicians, it would be like profile onto Cerner. And I guess for the whole clinic, it's scheduling from profile onto Cerner, because right now the whole clinic is scheduling into profile, right? That was what was communicated to us, and which is what we're using as information to plan these sort of sessions with your clinic and your team.
Marina, any thoughts? I see you worried.
Did you say that the physicians will be documenting in one part, in one area, and like in one program, and we will be documenting in different program? Like
The
what
plan is to have everyone document together in Cerner.
in Cerner? Okay.
And we're planning to go to implement Cerner late spring, early summer of next year.
And we will be on Paris until then.
That was the plan, yes. Hopefully the next few months fly by quickly. But that was what was communicated with us.
Okay, why don't we move on with the Cerner pieces and then we can revisit that later, just because I'm mindful that, you know, with the profile pieces, our clinicians wouldn't need any training. It would just be more us closing the Paris portions of the record in advance. And then I actually think there's more work on my end because I would need to make sure we're capturing all the interactions for overall stats. But anyways.
Okay. All right, so we can start from the very beginning. I know we kind of jumped in because Dr. Lai had some previous experience with Cerner, and Sally, I know you've seen this before with your hand clinic, but we're gonna start like from the beginning, like you've never seen Cerner before, and we'll take you from the top to bottom. So I will let Erica start off with some slides to kind of give you the general workflow, and then I can then go into Cerner. I can show you all the different applications and all the different screens and views. Okay, Erica, over to you.
Great. Thanks, Janice. Can you hear me? Janice?
I don't know if it's my connection, so I've
Can you
turned
hear
my
me?
camera off.
I think I've lost you altogether.
We can hear
Hey,
you,
everyone,
Erica.
can you hear me now?
Yeah,
Oh,
we
you
can hear
can.
you.
Have you been able
Yeah,
to hear me this whole time?
parts of
I
it,
was
I
saying,
think.
can you hear me like many times?
We can hear you pretty
Oh,
stable
okay.
now.
Well,
Yeah,
I'm
it's pretty
so
good
glad.
now.
I'm glad you can hear me now. I turned my camera off.
Okay.
There seems to be some kind of instability with the internet here at the location I'm at. So do let me know if something happens with the audio. What I'm going to do is share the first portion of the presentation with you, and then I'll likely log in and log back off while Janice is presenting the system. New folks that have joined us here at 2:30, but I will go through these introduction slides, and then we can get into kind of some Cerner background. So just starting us off in a good way and acknowledging the land on which we're gathered, the traditional and unceded territory of the Coast Salish peoples, including the Squamish, Musqueam, and Tsleil-Waututh nations. And for that, I am grateful. Here's our agenda for the afternoon. So we're going to talk about referrals. We're going to talk about just some background pieces. Janice is going to show you an intro to the system and kind of daily functioning. Then we'll leave some time at the end for questions, and then we'll talk about next steps. Any questions with that agenda or things you'd like us to add? All right, I'll keep going. So we ask that you please put yourself on mute when you're not speaking. When you are sharing, we ask if you can just mention your name if you haven't spoken before. This just helps our folks that are taking meeting minutes. If you have any non-urgent questions, you can pop those in the chat. And we are recording this video session, or we are recording this session via Zoom, and we will post it to YouTube unpublished so that we can go back and look at any design decisions. Is everybody okay with that? Going once, going twice, 3 times, we're okay? All right, I'll keep moving forward. So I know we did introductions in the first half, but so new folks have joined us. So if you are you weren't here in the first half and you are a subject matter expert from the GAP team. If you don't mind just saying your name and your role, just so the project team can hear your voice.
Hi, my name is Jin. I'm a PA at the GAP.
Hey, Jen, thanks for joining.
I'm Ed. I'm a physio at the GAP.
Hey, Ed, thanks for joining. Anyone else joining? Is Cam with us?
Hi there, my name is Sabrina. I'm one of the program supports for GAP as well.
Oh, awesome. Welcome. Thanks for joining. All right. So you'll see there's a number of people, all questions you just brought up about the existing systems. I'm excited to dive into some of that. We may not have time for it today, but we will capture it. But I'm here today because I'm actually learning Cerner for Community under the guidance of Janice Toulousin, and the CST team is also here supporting. So you'll notice there's a number of names over on the far side of the slide. The folks from CST will just jump in and answer questions as needed throughout the presentation, and they'll say their names and introduce themselves then. So thanks everybody for being on the line. All right, moving us forward. So we want to start from the very beginning and just do a quick clinic overview. So this is your clinic. We validated this before we dove in with Dr. Lai. And I had the phone numbers correct, so my apologies. I've corrected them on here. But just making sure that we have the right address. The right hour. It's on Saturdays and Sundays. Is that correct? Somebody just validate if that's correct from the SME group. Are you working on Saturdays and Sundays? Can you hear me, folks? Sally? Can you hear me?
Eric, I can hear you, but I think you're cutting in and out.
I think I am cutting in and out. I'm gonna have to log off. And do you
I
want
can hear
to?
you right now fine though.
I don't know if others can hear me, and nobody's responded back.
Yeah, Erica, you're in and out. We didn't get much of what you just said.
Oh no, I was making sure you weren't working on Saturdays and Sundays.
Yeah, we're not Saturday. No, we're closed Saturday, Sundays, and the times are correct.
Okay, thank you. Am I still going in and out, Edmund?
So far okay.
So far, okay. All right, I'm gonna have to log off, I think. I'm so sorry, everyone. Janice, can I throw it over to you to do a little bit of intro to the system while I log off and log back in?
Yeah, do you want me just to like dive right into the referrals section and just kind of go through those slides? Yeah.
Absolutely, that'd be fantastic. Thanks, Janice. Apologies for this, everyone.
Problem. Okay. I'm gonna turn my